Okay. I'm not this patient. Can you hear me? Okay. Amniotic fluid metabolism. Sorry, amniotic fluid embolism. Amniotic fluid embolism, risk factor, advanced maternal age, gravida 5 or more than 5, live birth or stillbirth, cesarean or instrumental delivery, placenta previa or abruption, preeclampsia, placenta previa or abruption preeclampsia, clinical presentation, shock, hypoxemic respiratory failure, shock, hypoxemic respiratory failure, DIC, coma or seizure. Shock, hypoxemic respiratory failure, DIC, coagulopathy, DIC, coma or seizure, and treatment is respiratory and hemodynamic support with or without transfusion. This patient likely has amniotic fluid metabolism, a rare but catastrophic complication, during pregnancy or the immediate postpartum period. Risk factor include advanced maternal age, grand multiplicity, placental abruption, and an operative caesarean delivery. Amniotic fluid embolism occurs when amniotic fluid enters the maternal circulation through areas of disrupted materno-fetal connections such as endocervical veins, areas of uterine trauma, hysterectomy, and initiates a widespread inflammatory response leading to the following: hypoxemic respiratory failure due to significant pulmonary vasoconstriction from the pro-inflammatory mediators, and physical obstruction from amniotic fluid debris, which can lead to severe hypoxia. The resultant profound hypoxia can cause coma and seizure, as seen in this patient. Obstructive shock due to increasing pulmonary arterial resistance, which leads to subsequent right ventricular heart failure and decreased left-sided cardiac output. These often allowed immediately by left ventricular failure and resultant pulmonary edema, cracking, and cardiovascular collapse. Hypertension and DIC causing profuse bleeding from multiple sites, uterine IV lines. Amniotic fluid embolism is diagnosed clinically and requires prompt recognition as complete cardiovascular collapse rapidly ensues. Treatment requires intubation with mechanical ventilation to correct hypoxemia, vasopressor to support blood pressure, and massive transfusion to correct the DIC. Despite early and aggressive intervention, few patients survive, and often with permanent and severe neurologic sequelae. Okay, next. Yes, carboprost, a prostaglandin that stimulate uterine contraction to treat pulmonary to treat postpartum hemorrhage from uterine atony. These patients bleeding from IB line suggest an etiology other than uterine atony. Carboprost does not treat DIC, may worsen. Carboprost does not treat DIC and may worsen the cardio and may worsen these patients' respiratory status due to bronchospasm. And choice C, heparin anticoagulation, is generally indicated for pulmonary thromboembolism, which can cause acute cardiopulmonary failure. Heparin should be administered in patients with significant bleeding or signs of platelet dysfunction. Okay, it's NRDS. Okay, neonatal respiratory distress syndrome. In neonatal respiratory distress syndrome, there is surfactant deficiency. In premature infant, there is surfactant deficiency in premature infant, increase alveolar surface tension, which leads to atelectasis, ventilation perfusion mismatch causing right to left intrapulmonary shunting. Clinical feature is tachypnea, retraction, grunting immediately after birth, cyanosis and hypoxia, and decreased breath sound. Chest X-ray shows diffuse ground glass appearance, air bronchogram, diffuse glass appearance, air bronchogram, decreased lung volume. Management is surfactant administration, respiratory support, continuous positive airway pressure, prevention by antenatal corticosteroid stimulate fetal surfactant production, and complication is bronchopulmonary dysplasia due to chronic lung disease. This premature neonate most likely has respiratory distress syndrome, a disorder characterized by surfactant deficiency. In general, around 20 weeks of gestation, alveolar cells begin to producing surfactant. Surfactant is primarily composed of phospholipid, which reduces the alveolar surface tension, and in preparing the gas change after birth. The quantity and the quality optimal phospholipid composition of surfactant increase throughout the gestation. In premature neonate, immature and insufficient surfactant results in increased alveolar surface tension and poorly compliant alveoli. The pressure required to keep the alveoli open upon expiration in those expiration is therefore increased and ultimately results in alveolar collapse. Diffuse atelectasis leads to the area of the lung that are perfused but not well ventilated. Ventilation perfusion mismatch, which results in hypoxia. Characteristics include increased work of breathing, retraction, nasal flaring, increased work of breathing, retraction, nasal flaring to minutes to hours after birth, and decreased breath sound and lung volume with a ground glass appearance on chest X-ray. Okay. Yes, yes, yes. Okay. Air leakage. Okay, air leakage into perivascular tissue describes pulmonary interstitial emphysema. Air leakage into lung perivascular Air leakage into lung perivascular tissue describes pulmonary interstitial emphysema, which presents with worsening hypoxia in a mechanically ventilated patient who requires high pressure to maintain oxygen. In contrast, this patient respiratory distress began immediately after birth. Meconium aspiration syndrome (MAS) leads to respiratory distress due to bronchiolar obstruction and inflammation from particulate matter like meconium. These patients' clear amniotic fluid makes this diagnosis unlikely. In addition, chest X-ray shows hyperinflated lung and streaky linear densities. Option C, defective surfactant metabolism. Defective surfactant metabolism and clearance can occur in pulmonary proteinosis, which can cause neonatal respiratory failure and ground glass opacity. However, this condition is exceedingly rare, making RDS more likely, particularly in premature infant. Bronchopulmonary dysplasia characterized by airway injury and pulmonary fibrosis in a in chronic lung disease in neonates who require prolonged more than 1 month of oxygen therapy. Although this patient is at risk of developing this condition, his age is inconsistent with the diagnosis. And choice E, impaired clearance of alveolar fluid. Impaired clearance of the alveolar fluid, which causes respiratory distress within hours of birth, occurs in transient tachypnea of the newborn. Unlike in this patient, chest X-ray shows fluid in the interlobar fissure, severe hypoxia, and requiring invasive respiratory support is atypical. In TTN, like transient tachypnea of the newborn, look at the X-ray fluid within the fissure fluid. And in NRDS, there is air bronchogram, diffuse diffuse ground glass opacity, and air bronchogram. Hyperresonance to percussion on the right side looks like pneumothorax. But is it pneumothorax? Okay. Foreign body aspiration, history of choking event with sudden onset cough. Symptoms depend on the location, trachea or main bronchus, acute respiratory distress, cyanosis, stridor, Cyanosis, stridor, hemoptysis, lower airway, chronic or recurrent cough. Examination finding focal, unilateral, and/or monophonic wheeze. Focal area of diminished breath sound. X-ray show hyperinflammation of the affected site. Mediastinal shift shows unaffected. Mediastinal shift show mediastinal shift toward unaffected site, and atelectasis if complete obstruction with or without foreign body. Complication recurrent pneumonia and bronchiectasis. Management bronchoscopic removal. Wheezing is the most chief complaint in children. It's primarily due to asthma or viral illness. However, sudden onset, unilateral wheezing, and unresponsive to sudden onset unilateral wheezing, unresponsive to albuterol raises suspicion of foreign body aspiration. So unilateral wheezing, unresponsive to albuterol, think about foreign body aspiration. Foreign body aspiration most commonly occurs in children aged 1 to 3 due to exploratory behavior and relatively narrow airway diameter. Following aspiration, patient classically develop abrupt onset respiratory distress, cough, dyspnea. The aspiration event may be unwitnessed and history of choking is not always present. History of choking is not always present. In most cases, the object partially obstructs one bronchi and resulting in progressive um, expiratory phase due to air trap distal to the obstruction. Wheezing and a decreased breath sound on the affected site are characteristics, and hyperresonance to percussion can occur on the hyperextended lung. Although X-ray may be normal, findings suggest of foreign body aspiration include unilateral lung hyperinflation with mediastinal shift toward the unaffected site as seen in this patient. Atelectasis may be present in cases of complete bronchial obstruction. Most aspirated objects are radiolucent and therefore not identified on X-ray. So management include immediate rigid bronchoscopy to confirm the diagnosis and remove the object. Yes, Pneumothorax can present abruptly with uh, cough and hypoxia, but does not typically cause wheezing. In addition, X-ray shows air without lung marking outside the pleural lung, and ipsilateral lung collapse, not hyperinflation. So pneumothorax in X-ray can show air without markings outside the pleura with ipsilateral lung collapse, not hyperinflation. In here hyperinflation, but uh, okay. Okay, can you give me 5 minutes? I'm coming. Okay. Okay, this patient with obesity and has a daytime sleepiness. And this patient with obesity and who has daytime sleepiness and appear to choke at night likely has obstructive sleep apnea. Obstructive sleep apnea from laxity of the pharyngeal musculature leading to transient upper respiratory transient upper airway obstruction and nocturnal hypoventilation in the reduced consciousness setting of the sleep. Typical manifestations include excessive daytime sleepiness, morning headache, impotence, poor judgment, and depression, a history of snoring and/or periods of apnea or gagging witnessed by the bed partners is often reported. Physical examination often demonstrate obesity, increased neck girth, which correlate with OSA severity. Sequelae of untreated OSA include systemic hypertension, pulmonary hypertension, right-sided heart failure, although tricuspid regurgitation, holosystolic murmur at the left lower sternal border may occur with pulmonary hypertension. This patient holosystolic murmur at the apex suggests mild MR, which can occur from variety of the etiology myxomatous degeneration, but is unrelated to pulmonary hypertension. Okay, yes. Airway inflammation, airway airway inflammation and hyperresponsiveness in the setting of asthma or COPD are the common cause of dyspnea. Although this patient has a history of childhood asthma, coughing and wheezing would be expected, and pulmonary venous congestion from congestive heart failure can cause congestive heart sorry okay see the alveolar arterial oxygen gradient, which reflects the efficacy of oxygen transferred from alveoli to the blood, is increased with conditions involving ventilation perfusion mismatch, pulmonary embolism, pneumonia, and impaired gas exchange. Interstitial lung disease in OSA hypoxia is due to nocturnal hypoventilation rather than impaired oxygen transfer. Therefore, although both alveolar and arterial oxygen content are decreased, the AA gradient is normal. Partus, Partusis. Are you thinking about Partusis? Pertussis. Okay, okay, we are right. We have done chest exam, but we diagnosed wrong. Okay, spontaneous pneumomediastinum. Spontaneous pneumomediastinum. It risk factor is airway exacerbation, respiratory infection, tall in adolescent boy. Clinical feature is acute chest pain, shortness of breath, cough, subcutaneous emphysema, and Haman sign, like crunching sound over heart, mediastinal gas on X-ray, and treatment is rest analgesic, avoid Valsalva maneuver. These patients subcutaneous emphysema over the chest consistent with spontaneous mediastinum, high intraalveolar pressure due to severe coughing, severe coughing paroxysms can cause air to leak from the chest wall into the subcutaneous tissue. Children who cough due to asthma or a respiratory infection are increased risk for spontaneous pneumomediastinum. A tall, thin adolescent boy presenting also involve acute chest pain, shortness of breath, acute chest pain, shortness of breath on examination, subcutaneous emphysema. On examination, subcutaneous emphysema typically palpated in the neck or precordial area. A crunching sound is heard over the precordium, Hammond's sign. In rare cases, spontaneous pneumothorax air in the pleural space can accompany spontaneous pneumomediastinum and present with diminished breath sound on the affected side. The first stage is chest X-ray to confirm the first stage to confirm the presence of the mediastinal gas to rule out mediastinal gas to rule out the pneumothorax. Life-threatening pneumothorax may require emergency needle thoracostomy. An uncomplicated SPM can be managed with rest pain managed with rest, pain control, and avoidance of maneuver that increase pulmonary pressure. Avoidance of maneuver that increase pulmonary pressure like Valsalva, and symptom typically resolves within days to weeks. Okay. Maybe pneumothorax because if you do intubation, uh, it it can cause pneumothorax, and there is absent breath sound on the right side. Okay, this patient with severe, this patient has COPD, severe COPD exacerbation, uh, wheezing, dyspnea, cough requiring mechanical ventilation, developed developed abrupt onset hypoxemia, associated with elevated peak and plateau pressure, measured on ventilator, and decreased right-sided breath sound. This presentation suggests pneumothorax or the presence of air within the pleural space. Pneumothorax may occur spontaneously. Or secondary to underlying lung disease, trauma, iatrogenic injury. Positive pressure ventilation, mechanical ventilation poses the risk of pulmonary barotrauma leading to alveolar rupture and pneumothorax formation. Patient with COPD are at greater risk. Patients with COPD are at greater risk due to pre-existing pulmonary hyperinflation. The presence of bulla and the blebs which can rupture. Patient presence of bulla and blebs which can rupture. Patients with large pneumothorax. Patients with large pneumothorax often demonstrate abrupt onset tachycardia, tachypnea, hypoxemia, and decreased or absent breath sound. The collapsed lung receiving a relatively stable volume of air from the ventilator, resulting in increased peak pressure, a measure of increased resistance to airflow from the ventilator, and increased plateau pressure, a measure of the lungs' decreased ability to expand. Compliance management of pneumothorax involves placement of chest tube which allows re-expansion of the lung. Okay, yes. Right mainstem bronchus intubation, which could cause hypoxemia and elevated peak and plateau pressure due to limited volume of the ventilated right lung, but would cause decreased breath sound on the left and unventilated lung rather than in the right lung as in this patient. Okay, right mainstem bronchus cause decreased breath sound on the left side, like the unventilated area, not the right side in here. Okay, this is the key. Respiratory acidosis. Okay. This patient's presentation is consistent with severe acute asthma exacerbation, impending respiratory failure. Acute asthma Acute asthma typically causes respiratory alkalosis, pH high, pH is high, PCO2 is low due to increased respiratory drive, therefore elevated or even inappropriately normal. Therefore, elevated or inappropriately normal PCO2 is concerning for respiratory muscle fatigue. Although this patient PaCO2 is not significantly elevated, it it signal impending of it signals impending failure given his tachypnea and his work of breathing, that is extreme effort to maintain relatively normal ventilation. Absence of wheezing, that means silent chest, is another alarming sign signifying poor tidal volume, poor tidal air movement. Severe asthma can cause significantly lower airway obstruction, inflammation, bronchospasm. The effect of pharmacologic therapy, nebulized bronchodilator, systemic corticosteroid, and IV magnesium will likely be delayed. Therefore, the immediate priority to stabilize the exacerbation with mechanical ventilation, non-invasive or invasive, as a breeze of recovery. A time-limited less than 2 hours trial of non-invasive positive pressure ventilation, non-invasive positive pressure ventilation can be considered in select patient. However, unlike with severe COPD, COPD, data on mortality and intubation rates with NIPV in asthma exacerbation are scarce and weak. Non-invasive pulmonary pressure ventilation instantly improves the COPD related hyperinflation, in which collapsible airway can be stented and opened by extrinsic pressure. In contrast, severe asthma is marked by concentric smooth muscle hypertrophy, and exacerbation typically involves inflammatory edematous airway closure that is not as readily relieved by positive pressure. Therefore, there is a low threshold to intubate and begin mechanical ventilation. Yes. Failure of the respiratory failure in Features of the respiratory failure in asthma: absent or minimal wheezing, poor air movement, silent chest, accessory muscle use, and altered mental status. Lab shows AVG, there is poor ventilation, increased PaCO2, decreased pH, poor oxygenation, that is decreased PaO2, lactate transient increase due to muscle work of breathing type 1 or beta agonist induced type B. Potassium transient decrease due to beta agonist and or respiratory alkalosis. Management is nebulized albuterol and ipratropium, IV corticosteroid, with or without IV magnesium. Short trial, less than 2 hours of non-invasive pulmonary pressure, non-invasive positive pressure ventilation, and low threshold for intubation and invasive mechanical ventilation. Okay. Ipratropium, anti মানে muscarinic agent. Is it epiglottitis? Inspiratory stridor, leaning forward, sitting up, leaning forward, drooling. Is it lateral net X-ray? Okay. Epiglottitis present with high fever. Epiglottitis present with high fever and acute onset respiratory distress, dysphagia, drooling. Young children are particularly vulnerable to life-threatening airway obstruction due to narrow caliber of their airways. They may assume tripod positioning, sitting, leaning forward, hyperextending neck to minimize obstruction. Initial management is to secure the airway due to risk of complete airway obstruction in epiglottitis. The patient should be kept calm. Aggravating intervention, detailed oropharyngeal examination should be minimized because agitation may cause laryngospasm. In children with respiratory distress such as this patient with stridor, retraction and cyanosis, endotracheal intubation should be performed in a controlled setting. Endotracheal intubation should be performed in a controlled setting, emergency department, operating room with trained personnel anesthesiologist available due to risk of obstruction. Patient may require surgical airway, tracheotomy, needle cricothyrotomy if attempts at intubation failed. If attempts at intubation. Higher. Yes. JVD is a feature of right heart failure, isn't it? Right heart failure, RHF, like raised JVP, hepatic. In cor pulmonale, there may be hepatic edema. Sorry, um, hepatomegaly. Sorry, it can cause hepatomegaly. It can cause ascites. No, but it cannot cause lung. Sorry, it cannot cause raised GBP. Okay, this patient's presentation suggests core pulmonary defined as right heart failure from pulmonary hypertension. Pulmonary hypertension may be idiopathic or due to chronic obstructive pulmonary disease, interstitial lung disease, idiopathic pulmonary fibrosis, obstructive sleep apnea, pulmonary vascular disease, thromboembolic or chest wall disorder, kyphoscoliosis. Right heart failure due to left-sided or congestive heart disease is not considered cor pulmonale. COPD is the most common cause of cor pulmonale in the US, with nearly 25% of the COPD patient develops with this disorder. Cor pulmonale typically has gradual onset but can present acutely due to sudden increase in the pulmonary artery pressure, pulmonary embolism. Patients often develop exertional symptoms, dyspnea, angina, syncope. Physical examination may show loud P2 pulmonary component of the second heart sound, tricuspid regurgitation, murmur, holosystolic at the left lower sternal border, elevated JVP, peripheral edema, hepatomegaly due to hepatic congestion, possible ascites. COPD patient usually COPD patients usually have distant heart sound due to hyperinflated lungs. End stage or call pulmonary may be hypotension. End stage call pulmonary may be hypotension. So tachycardia and hypotension and tachycardia and other signs of cardiogenic shock due to decreased stroke volume. Chest X-ray may show enlarged central pulmonary arteries, and loss of retrosternal air space due to right ventricular hypertrophy. ECG shows right axis deviation, right bundle branch block, right ventricular hypertrophy, and right atrial enlargement. Right heart catheterization is the gold standard for diagnosis and typically shows enlarged central venous pressure, right ventricular end diastolic pressure, and mean pulmonary diastolic pressure more than 25 mm at rest with supplement without left heart disease. Treatment involves optimizing right ventricular dynamics, preload, afterload, and contractility with supplemental oxygen, diuretics, treatment of underlying etiology, and IV inotropes for severe decompensation. Okay, yes. So, right ventricular failure due to pulmonary disease and resulting pulmonary hypertension. Right ventricular failure due to pulmonary disease and resulting pulmonary hypertension, chronic hypoxic vasoconstriction, COPD, ILD, obesity, hyperventilation syndrome, and pulmonary thromboembolic disease, absent of left heart disease. Symptoms: exertional fatigue, weakness, syncope, decrease due to decreased cardiac output, exertional angina, increased right ventricular oxygen demand, and venous congestion, abdominal distension, early satiety. Precordial heave due to right ventricular hypertrophy, loud P2 due to pulmonary hypertension, right-sided S3 and S4 hollow systolic murmur of TR, mm, JVD with hepatosventricular reflux, ascites, peripheral edema, hepatomegaly. Okay. Which of the hypotension, tachycardia, distended neck vein. She has undergone colonoscopy, routine colonoscopy. Think in that way. So recent procedure: hypotension, tachycardia, tachypnea, distended neck vein, lungs are clear to auscultation. Looks like PE. Yes. Yes. Sorry, I picked wrong, but I was guessing that it is pulmonary embolism. It is pulmonary embolism. Yes. But but the other feature looks like pericardial tamponade, like hypotension, distended neck vein, not distant heart sound. That is the key. It is not pericardial tamponade. Like distant heart sound, that like you are unable to hear the heart sound in pericardial tamponade, but in here heart sound is normal. Okay, you pick one. Look, a massive pulmonary embolism can cause right ventricular outflow obstruction, the first line of the flowchart. We need to remember the pathophysiology, then we can answer. So, massive pulmonary embolism, it can cause right ventricular outflow obstruction and increased right ventricular pressure. Increased right ventricular pressure will cause increased right ventricular dilatation. Increased right ventricular pressure cause right ventricular dilatation, increased right ventricular wall tension, increased right ventricular oxygen demand, and in here it can cause increased right ventricular hypokinesis, decreased right ventricular output, decreased left ventricular preload and cardiac output, decreased right ventricular oxygen supply, and thus uh, decreased right ventricular ischemia and infarction and right ventricular failure. Okay, these patients underlying malignancy. These patients underlying malignancy, an acute presentation of dyspnea, chest pain, tachycardia, hypoxia, clear lungs. Dyspnea, chest pain, tachycardia, hypoxia, clear lungs, suggestive of pulmonary embolism. Patients with massive pulmonary embolism can present with syncope and hemodynamic collapse. Examination may show accentuated loud pulmonary component of the second heart sound and elevated central venous pressure, elevated high jugular venous distension, high JVP, high JVP. Acute massive pulmonary embolism results in abrupt increase in the pulmonary vascular resistance, and subsequently right ventricular pressure. Elevated right ventricular pressure causes increased right ventricular wall tension, cardiac muscle stretching, right ventricular dilatation. These increases right ventricular myocardial oxygen demand, decreases coronary artery perfusion, which causes supply and demand mismatch and right ventricular ischemia. Consequent right ventricular dysfunction can lead to inability to pump blood through the pulmonary circulation and decrease venous return to the left atrium, decrease cardiac output, and possible hemodynamic collapse. Show bowing Bedside echo show bowing of the septum into the left ventricle due to right ventricular pressure and right ventricular wall hypokinesis sparing the apex. The presence of right ventricular dysfunction along with increased BNP and troponin level associated with increased mortality risk. It may be difficult to differentiate PE from right ventricular myocardial valve infarction, which causes RV dysfunction. However, right ventricular myocardial infarction is less likely right ventricular myocardial valve infarction less likely cause dyspnea or syncope. More likely to cause bradycardia or arrhythmia. Acute CD and E. Acute massive PE can cause right bundle branch block on ECG. New onset left bundle branch blocks suggest acute MI. Right bundle branch block. Dyspnea, hypoxia, dyspnea and hypoxia in acute MI is due to pulmonary edema, which this patient does not have. Mechanical widening may be seen in patient with mechanical widening may be seen in patient with aortic dissection. Patients typically present with sudden onset tearing, chest pain, back pain that may rapidly lead to hemodynamic collapse due to aortic rupture. Dyspnea and marked hypoxia are uncommon. So dyspnea and marked hypoxia is a marker of PE. Malignant pericardial effusion can result in pericardial tamponade. However, although pericardial metastasis is common in lung cancer and lymphoma, it can rare in colon cancer. In addition, tamponade can present with hypertension, but it would not cause dramatic hypoxia. Okay, have you done your breakfast? Okay, then go. Okay.